Dr. Shannon Clark, sorry, is a double board certified OBGYN and maternal fetal medicine specialist and professor at a large academic center where she has roles as an educator, clinician, and researcher. And you can find her, as you can see, actually, I guess on your name there, at TikTok Baby Doc.
Yeah.
Here on TikTok. And then now, if you are wanting to find her though on her other platform, which is Instagram, there you have your baby's over 35, aren't you?
Well, baby, it's I do a lot. Actually, I do a lot more on Instagram than TikTok. Babies after 35, but I educate on everything. It's not just about having babies after 35. I kind of educate on a little bit of everything. So yeah, but that's where I mostly interact with my followers is on Instagram.
Right. Well, anyway, happy to have you on this platform as well.
Yeah. Thank you for having me.
Yeah, this is going to be great. So, I think the reason we're here is because first we, for those of you who missed it, the first thing we did was we had an interesting discussion about meconium and the effects on the fetus, the effects on the newborn, and what to think about antenatally. And then we got into the topic of what should we talk about next. And as a neonatologist and a maternal fetal medicine specialist, it seemed that a great topic would be twins. And I have to say, one of the things that I've learned about you, Shannon, is, and you told me this, is, a lot of the stuff that I post, because a lot of it has more of a maternal fetal medicine slant, a lot of it does, winds up you getting tagged on. So I saw you just commented on another one of the hepatic topics. Although that one was interesting because to me it wasn't a true hepatic. It was like the placenta was on the liver, but the baby was actually in the abdomen. But but regardless, so we certainly interact, and so twins is a popular topic. It's something that a lot of people I think have interest in, and so one of the things and I'm pleading ignorance here. I'm about to tell you something that from medical school, but I seem to remember there was a formula I learned in medical school about the incidence of twins being forgive me if I'm wrong, but it was something like the natural incidence of twins was like 1 in 89 to the n-1 or something. So it was like the incidence of natural twins was 1 in 89. The incidence of triplets would have been, where n is the multiple. Triplets was like 89 to the second power and so forth. But that's changed a lot, hasn't it? I mean, with reproductive technology. So how common is it now?
So it's definitely much more common with the use of ART, especially prior to the new implementation and recommendation from ASRM. And ASRM is the American Society for Reproductive Medicine. And they're the ones that, it's kind of like my equivalent for MFM, the Society for Maternal Fetal Medicine. It's not a governing body, but they kind of put forth recommendations and guidelines for care and practices regarding reproductive endocrinology and infertility. So and I have the stats here for twins as of 2017 is really the last most recent data we have as far as twins with assisted reproductive technology. But right before that, and then especially now, they are promoting the single embryo transfer. So even since most centers are starting to adopt that policy after 2017, roughly, that incidence is even lower. We just don't have the formal numbers yet. So let's see, according to the most recent data for 2017, 25.5% of pregnancies conceived with ART were twins. And then 0.9% or 1% were higher order multiples. And that means 3 or more, okay? But since then, it's gone down, like I said, because of the implementation of the single embryo transfer recommendations for undergoing IVF or ovarian hyperstimulation with gonadotropins. Those are the 2 most common ways if you're undergoing assisted reproductive technology. IVF and then controlled ovarian hyperstimulation with the gonadotropins are the 2 common methods that are known to produce multiples.
Yeah, and so we're in different countries. So for those, I didn't introduce myself, but I think people who are following this, I think probably know a little bit about me. I'm a neonatologist, so I take care of newborns here in Canada and central Canada. And the practice here has really not been much different than it is in the US. I'm not as well versed in the obstetrical guidelines here in Canada, but I do know that there's been a move towards single embryo transfer, at least at the outset. It's another story if you've had multiple attempts,
Mm-hmm.
and you would be well versed in that. I mean, there's many reasons why
Yes.
women would choose to have more than one implanted.
Mm-hmm.
It's not a cheap endeavor.
Mm-hmm.
Here in Canada, and actually that's something that I think people might be interested in knowing. Um, yes, I'm in a socialized healthcare
Mm-hmm.
system, but you better believe the government does not pay for your embryo transfers.
Mm-hmm.
um, this is not deemed to be a necessary medical treatment. Um, it's something that is considered elective, and I think there's a whole debate that one could have about that as to whether or not it should be covered.
Mm-hmm.
But I am aware, for people who have finite resources, it does become an issue potentially. And I don't know if you can speak to that in the U.S. Like, do you have, when the advice is to do single embryo transfer, do you have families that literally say, you know what, I can afford to do this once?
Mm-hmm.
So
Yeah,
let's just.
well, let's make sure we know. I am not a fertility specialist. That's
No,
not
I
what I
realize
do.
that.
Yeah.
Yeah,
So
yeah,
basically, so here's just to sum it up. The reason why the new recommendations are for single embryo transfer are because of the complications, both pregnancy related and the maternal morbidity and complications with twin gestations. And not only that, but the risk of pregnancy loss and the neonatal complications from twin pregnancies and higher order multiples are significantly increased with IVF and having more multiple gestation pregnancies. So there's also some data that is still being teased out, but sometimes if you put in two embryos, it could be that if one embryo is not taking, it could affect the implantation of the other embryo. So that's another line of thought.
right.
So what they found is if someone has three embryos, putting them in consecutively, meaning try one, then try the second, then try the third, tends to have a higher success rate than if you put in two at the same time. So there's multiple reasons why that recommendation is there. Now, as a patient, I could see where people are like, just put two in. I want the best chance
Yeah.
possible, but it's not
Hmm.
always giving you the best chance possible because it doesn't necessarily increase your chances of getting pregnant, number one. And number two, the complications of the pregnancy, especially if it ends up being twins. So why are some of the reasons that people would want to put in two? The main reason, and I was one of those people, I had multiple failed transfers. And then financial implications as well. If I could get two babies instead of one, that I don't have to do this again. So, what they're basically recommending is what ASRM is saying is we're not discounting those reasons that are not necessarily medically related for why we shouldn't do it putting in two or more, obviously not more. We also have to consider the individual and why they might want putting in two instead of one. But there has to be serious counseling on behalf of the reproductive endocrinologist about the complications of twin pregnancy and pregnancy loss with doing that before making that decision. I went through 5 rounds of IVF myself, from
Wow.
age 41 to 40-ish to 43. I had a miscarriage and then 2 failed embryo transfers. I was over age 40, and we did put in 2 and ended up with twins, but I also almost lost them. And of course, I'm on the other end of that. They delivered prematurely at 31 weeks, but from 22 to 30 weeks, I was hospitalized. So I've seen it all, not only as a physician, but as a patient, and knowing the risk of having twin pregnancies after age 40 and by IVF. So those are all things to consider. Putting in
Wow.
two doesn't always give you a guarantee for anything. So that's why ASRM is strongly encouraging the single embryo transfer policy.
Well, thank you, and
Mm-hmm.
and Shannon, I should say thank you for sharing your backstory as well. I know
Yeah,
you've shared that at other,
yeah.
at other times, and I'm sure that resonates a lot with a lot of the
Mm-hmm.
people that may be watching or have been following along. And one of the things that I just wanted to mention is I'm relatively new to these whole likes and roses, but
Mm-hmm.
to Blonde Princess 22 who sent us 10 roses, thank you very much.
Thank you.
And to those of you who are sending likes, thank you, because I understand it that part of what the likes do is likes will draw people to the session, and who knows, somebody might who's watching out there learn something today, such as about embryo transfer or
Mm-hmm.
something about your story that you've had that certainly will resonate with them and may be therapeutic. And
Mm-hmm.
I think I would speak for both of us knowing a little bit about how you what you post about, what I post about. In general, my goal is to try to make as many people happy as I can. I try not to post too many things that are of a negative sort. So appreciate that. Um, one of the things, that I get asked a lot about to post about, because I wind up posting a lot on fetal MRI, other CT
Mm-hmm.
imaging, and so forth. People are always interested in the zygosity of twins. So monozygotic, dizygotic, um, and di, mono, di, and so forth. And one of the things that I was hoping we could just talk about for people, because one of the things that I think is important that people realize is not all twins are the same.
Right.
There's a big difference between di and mono mono, and so this is your field as an
Mm-hmm.
MFM person. What are, like, when a woman comes in and she suspects she has twins? Maybe we can just begin with, how do you tell? How, like,
Yeah.
what are you looking for in the ultrasound so you
Mm-hmm.
can confidently turn to the woman and say, or the family, and say, congratulations, you're having twins,
Mm-hmm.
and they're either mono mono or mono di or
Yeah,
di.
yeah. So let's talk about first how they're made. So twins, we're limiting this conversation to twins. Where triplets and higher order multiples will be for another conversation. Let's just talk about twins. So twins are going to be occur from one of two reasons. The first reason is two eggs are released and fertilized at the same time. They come down, they're both fertilized with sperm, and they implant, and you end up with something called di-twin gestation. That means each twin has its own placenta, each twin has its own chorion, and each twin has its own amnion. Those are the two layers of the sac that ends up, around the fetus and inside the uterus as the baby's growing. The amniotic fluid's on the inside, and then a fetus. The other way is if one embryo comes down, one egg comes down, gets fertilized, but it splits really, really early, like less than 2 days or even earlier than that. If it splits early enough, you could still end up with di twins. The only difference is the first way that I described, they're fraternal. They don't have the same genetics. Whereas at the first one, the second scenario I'm explaining, where the egg gets fertilized early enough and then splits, that could still be di on placentas, on amnions, on chorions, but they're identical, if that makes sense. So
Mm-hmm.
that's how you get di twins that can be either fraternal or identical. Then say you have one embryo that comes down and gets fertilized. The later on it splits is how the different types of twins are made. So you have the one egg fertilized, it starts to form an embryo, it splits really early. That could be a di twin. It goes a few more days, it splits. That could be something called monodi, monochorionic, diamniotic, so it has one placenta, one chorion, and two amnions. So they're separated by a thin membrane. Then you go on down, it splits a little bit later. That could be something called mono twins, monochorionic, amniotic, and it's one placenta, one amnion, one chorion, and they're in the same house, in the same sac together. And then go down and split a little bit further, then that's where you can get the conjoined twins. Okay, so what are we looking for to tell what kind of twins they are? The earlier you get a ultrasound, the better and the easier it is for us to see the membranes. So say I have someone that's in the first trimester. I'm going to look for where the placentas are. Obviously, if they're in two separate locations, they're di. No question. If one's on the top of the uterus and one's on the back, there's no communication. Those are di twins, and the dividing membrane, which separates the two twins, is going to be nice and thick. Now, I still can't tell whether or not it was one egg that split into two or two different eggs that were fertilized, but those are di twins. If they are monodi, I'm going to see one placenta and then a thinner membrane in between, because you have a monochorionic and diamniotic. So you're just going to see one smaller, thinner membrane, okay? And that's going to tell me that they're the same placenta, but they're in two different sacs, monochorionic, diamniotic. Next one would be mono. One placenta, one amnion, one chorion, and you see the cords. There's nothing in between them, no what we call a dividing membrane. Then that tells me they're mono. And what you're worried about with that is that because there's no way to separate the two twins, those cords, umbilical cords, can get entangled. So cord entanglement's the biggest risk you have with mono twins. If you back up to mono-di twins, twin transfusion syndrome is the main thing you worry about with those. And we can talk about that later. And then obviously if they're conjoined twins, they're conjoined twins. Those are going to be mono twins. And then you just determine the best that you can. You usually can't tell earlier on in pregnancy. That's going to be done later when you're able to get additional imaging to tell exactly what kind of conjoined twins they are. Does that answer your question? The bottom line is the earlier you get the ultrasound, the better. I've had twins come in. I've diagnosed twins all different ways. They've come in and you couldn't tell because the further along in the pregnancy they are, you may not see that dividing membrane as well. And the placentas are also bigger, and as they get bigger, they might be really close together and not necessarily connected, but I can't tell on ultrasound. So sometimes you just don't know. The earlier you get the ultrasound, the better, and the easier it is for us to tell what kind of twins they are.
Yeah, and from the neonatologist standpoint, um, the mono and the mono di are the ones that generally come to my attention.
Yes.
The mono, interestingly, we don't often see, as I mean, they're rare. They're rarer. We don't often see a lot of problems in them other than prematurity, because I know that I don't care where you practice. When they come along, everybody's watching for the cords to get entangled, and you wind up delivering them often early, and then we have to deal with them in the NICU, which we're happy to do. And you mentioned twin-to-twin transfusion, which is the real topic that I wanted to get to when we're talking about twins, because in the comments that I see a lot of comments about, can you talk about twin-to-twin transfusion syndrome and what is it? And so I thought, yeah, maybe what we can do is, if you want, you can maybe talk about what you see antenatally, and then I can maybe talk a little bit about the things that we see postnatally. And just because there may be somebody out there, I've seen a few comments already about different types of twins that people have that are watching. So why don't you go ahead?
Yeah, so that's another reason why getting that ultrasound earlier in the first trimester is better for twins, because if they are diagnosed as monochorionic diamniotic, the twin-to-twin transfusion possibility is there. And we can start the surveillance when we normally do, which would be at 16 weeks. You start doing what's called twin-twin transfusion surveillance with ultrasound. And why do we do that? Because you have two babies that share the same placenta, but they're separated by a thin membrane. But what you don't see on ultrasound, I can't see this on ultrasound, but the placenta has vessels that are connecting each sac that the baby's in. Whereas if they're di and have separate placentas, that can't happen. So that's when that can happen, and they can share blood flow back and forth. What can happen is, if there's enough of an imbalance of those vessels, and one fetus is getting more blood flow than the other one, the first thing you might see is that the amniotic fluid starts to get a little discordant, meaning one fetus might start having decreased fluid and one might start getting more. Then you might see that one fetus doesn't have a bladder, or either one doesn't, they both don't have bladders. Then the growth might start to be discordant. One of the worst, and I've seen this before actually multiple times when people didn't know they had twins and they came in later for prenatal care, is something called a stuck twin. That means that the process was already well into play by the time I got them, and the baby that doesn't have the fluid is actually stuck to the side of the uterus because there's no fluid there, and that membrane's kind of wrapped around that baby. That baby's going to be smaller. This baby over here is going to have a lot of fluid and be bigger because it's getting more of the blood flow, because there's a shunting of the blood to that baby. So basically you have a recipient twin in that situation. The recipient twin is the bigger baby with the more blood flow and the more fluid that's getting most of the blood. Then the donor twin is donating its blood flow and everything to the recipient twin. It's smaller. It doesn't have as much amniotic fluid. And because it's not getting as much blood flow, it's also not going to be peeing, which decreases the amniotic fluid as well. So, those are the things that we are doing surveillance for. Like I said, we can't see the vessels on ultrasound. So if there's something called Quintero staging that, and I won't go through that because it's kind of technical, but there's different stages of twin-twin transfusion. And then once we start seeing that, we put them in a stage. Once they get to a certain stage, depending on where you're at, and if there's a facility near you that does laser therapy for twins, we have a center that we use in Houston that does this. What they do is they can go in once they meet the criteria and they have certain criteria that makes them candidates for this laser therapy. They actually take a camera into the amniotic sac, and they look for the surface vessels on the placenta, because you can see some vessels on the surface of the placenta. You cannot see the deeper vessels with this. But if they see the surface vessels and they see those communicating vessels, they can laser them to keep that blood flow from shunting over to the recipient twin. Like I said, you can only see the surface vessels. You can't see the ones deep. You can't do anything about the ones deep, only the ones that are surface related. And that's one treatment that we potentially have if we can catch that twin-twin transfusion early enough. So if you have twins and they're monodi and they're telling you need to come in for all these ultrasounds, yes, it's a pain in the butt because you're getting ultrasounds all the time. But there's a reason why, because you want to catch twin-twin transfusion syndrome as early as possible, because you have more you have more
That's quite all
opportunity
right.
to intervene and get a better outcome for this pregnancy. Once it gets so far out in the process to where you might have a stuck twin and one baby's already growth restricted, the other baby's really big, it might even be what's called hydropic, because it's gotten so much blood flow that it's starting to, if anybody's listening knows what congestive heart failure is, people start to get swollen because they're retaining so much fluid. That's kind of what happens in that recipient baby. Once it gets to that point, then the outcome may not be very good for either twin, and you can talk about that. So that is kind of in a nutshell. It's a little bit more complicated than what I'm explaining. I try to explain it as simply as possible, but the takeaway message is, if you have monodi twins and they're telling you need surveillance, do exactly what they tell you, because you want to catch it early.
Yeah, and I appreciate everything you just said, and of course, spot on. I do want to just have a shout out here to Kay Wriggle, sorry, only because she mentioned my OB for my last pregnancy specialized in twin-to-twin transfusion surgery. She didn't put the first name, but it's Dr. Greg Ryan in Mount Sinai in Toronto, and I had the pleasure of working with Greg in 1997.
Yeah.
I spent a month working at Mount Sinai with Dr. Ryan when I thought I wanted to be an OBGYN, doing exactly what you do. So I worked with him. And have you ever met him?
No. We work with a center in Houston.
Yeah.
I'm on the.
And I was going to say, kids are absolutely fine. The last live I did, I had my child pop up into the live view over my shoulders. So that's just part of life. But I wanted to share a story with you, actually, about twin-to-twin transfusion syndrome, because to date, this was the most dramatic thing that's ever happened in my career, and it had to do with twin-to-twin transfusion. I was a young neonatologist. I think I'd been in practice maybe 7-8 years. And I got a call one night that a woman with monodi twins, who'd been followed throughout, just like you said, had been followed very frequently, had ruptured her membranes, and there was a stuck twin and a twin with a lot of fluid, which we call polyhydramnios. And so they said that she was going to deliver. They needed me right away. I'm at home. I get in my car. I'm racing there, and the MFM calls me and he says, "Michael, I don't want you to get in an accident. We've been waiting for this twin to pass away. The stuck twin, we've been on watch for days and days and days and weeks." And he says, "Please don't rush in and get in an accident, because this child will not survive." So anyway, I get there, and the baby's been born. This is, honest to God, this is a true story. This is the most incredible story of my career. The baby is on a special type of ventilator, a high frequency ventilator, is doing terribly, has no signs of life. And I know you're probably thinking, Shannon, how is this a good story? So has no signs of life. And so at some point, I just, I did some initial steps of resuscitation. We gave some epinephrine. Things are not going well. And so I meet with the dad and I say, Mom still hasn't delivered, by the way, the other twin. I meet with the dad and I say, I think, sir, we've done everything we can. He agrees. We take the breathing tube out and we bundle the baby up, give him to dad. 10 minutes goes by, 15 minutes goes by. Mom's still laboring, still trying to deliver the other twin. They're holding what they believe to be the deceased child. So I go in, and this baby was as black as could be. Just looked horrible. Again, you're still wondering, how is this a good story? So looked absolutely horrible. And I'm talking to the father. I'm checking on them. And out of my peripheral vision, I could swear I see the baby blink. And I thought, you're seeing things. This can't be. And then I start talking to the dad again, and I see the baby blink again. And I thought, what is going on? And so anyway, I said, it was the most awkward thing. Mom's laboring, and dad's holding what he believes is his deceased baby. And I said, I know this is a weird question, but I said, could I just take your baby back for a minute? And he says, okay, awkwardly. And I take the baby to the next room. We unbundle the baby. The face is black, but the body's pink. And the baby starts kicking and moving around.
How many weeks was she?
27.
Do you remember? Mm-hmm.
27. And I was stunned, absolutely stunned. Anyway, that baby did okay. That baby in the end did okay. And I considered it, it was like a near miracle.
Mm-hmm.
And at some point, one of my colleagues, I was relating the story. I'm not a terribly religious man, and that's something that I guess that's a whole other TikTok forum, I'm sure. But um, one of my colleagues was trying to explain to me how this could have happened, and I looked at her and I said, I put my hand up like this. I said, you know what? I said, I get that you're trying to explain this, but I said, I believe I witnessed the hand of the Almighty come down, touch this baby, and she said, come on, you're a man of science. And I said, I'm actually good with hand of God on this one. I said, I was there.
Yeah, I think this is thanks for sharing that, because, for a couple of reasons. Number one, we as physicians, and as you being a neonatologist, me being a maternal fetal medicine specialist, we see a lot of very heartbreaking things.
Mm-hmm.
And I've learned years ago, even in the situations where I know in my science brain that the outcome is likely not going to be very, very good, I never say, I try not to ever use the word gonna die, dead, for anything, because I don't know. It's not my job to say something as definite as that. And I don't ever want to take away anyone's hope. I think what we should do in these situations, especially when we know, like I said, in our science brain, that either due to the size of the baby or the circumstances that it's probably not going to do well, the thing that we should do is educate, let them know what the options are, let them be involved, meaning the parents, be involved in what's going on, and let them make those decisions with us. I train my residents, don't ever say, you're going to die if you don't do this, or your baby's going to die if you do this, or there's no chance for your baby, because we don't know those things. But at the same time, you also don't want to make it seem like the docs are either not doing their job, if they don't have the best outcome.
Right.
It's a very fine line. And I think being transparent and involving the parents in these decisions. And also, on the other hand, and on the flip side of this, and I went through this, I got hospitalized with my twins at 22 weeks. And I had to make some decisions and change it every week as to what I wanted to do for resuscitation should I go into labor and deliver my twins at 22, 23, 24 weeks. And so for those patients or anyone that's listening that does not want resuscitation, especially that early or in those situations, that's fine too. Do you see what I'm saying? Because I don't want people to think that they have to agree to something, or that they're bad if they don't agree to that. Am I making sense? Because it's up to the family. Sense. It's a very personal decision on to resuscitate or not in those bad situations where the fetus or baby may not do well, and it's okay to want everything done, right? So
you can always try.
Yeah.
And one of the things that I think we've really moved to, and I think I have to advocate for it. One of my roles is I'm chair of the Fetus and Newborn Committee, which is the Canadian equivalent of the Committee of Fetus and Newborn with the AAP. And we really moved to a shared decision model. At edge of viability.
Ask your dad.
And in this type of situation, I don't think it's right for us to be paternalistic. I mean, I don't. I also think this is going to drift a little bit, I suppose, but I also think we have an obligation as the experts to share an opinion. I think we're not serving our patients well if we simply say, well, here's option one, here's option two, what do you want? I think that we do need to say to them, in our experience, as I say that, there's a colleague, an Irish colleague of mine, who once, when I said in my experience, it was just an expression that I used to use, and I was in my last year of my fellowship, and he looked at me, he was much older, and he said, what experience is it that you have?
Yeah, you're as green as they come. How much experience?
Yeah, you're pretty green. No, but I do think that we need to offer
Yeah.
You know, I do think that we need to offer our expertise, but
Mm-hmm.
ultimately, if the family wishes to, you know, even in the face of overwhelming odds, if they say we
Mm-hmm.
want to try,
Yeah.
well, you know what, you can try, and the
Mm-hmm.
vast majority of the babies who are not destined to make it will
Mm-hmm.
declare themselves in the first 24
Yes.
hours. And
Mm-hmm.
and I think the disservice we do to our patients, sorry, is when we take that decision away from them. When we say, I'm sorry, there's no hope, there's no
Mm-hmm.
chance, we go home, we move on
Yeah.
with our lives. But that family, perhaps every year at the minimum, on the anniversary of the loss of that pregnancy,
Mm-hmm.
will wonder, what if I had at
Yeah.
least tried?
What
Right?
if? Yeah. What
What
if?
if? What if? So
Mm-hmm.
take away the what if. If they want to try, let them
Mm-hmm.
try.
Mm-hmm.
Um, I should mention that somebody joined and they asked, what is it that we're talking about here? So we're
You're
talking
right.
about twins.
We're drifting a little bit.
Yeah, somebody just joined in. So we're talking about twins. And what we were also talking about, and thank you for the likes that people are sending, appreciate it. Um, what we're talking about right now is twin-to-twin transfusion syndrome, and I just wanted to share a little bit about, you know, what to expect. And there's some questions that we'll get to, but what to expect in the newborn. So from my standpoint, where things get very interesting is you have sort of an opposite set of problems that happen
Mm-hmm.
with the two twins.
Mm-hmm.
And one of my friends who's a neonatologist is on, so he'll keep me honest. The NICU doc,
Mm-hmm. Well, that's okay.
but
Let's digress. Or let's digress for this. Touch on this one part. Is like,
yeah,
when do we deliver twin transfusion? So
sure,
that's typically my decision, if you will, for, as a maternal fetal medicine specialist. There's multiple factors at play. How the twins are doing, you know, on the monitor, how they're growing, what the blood flow is doing. We measure the blood flow from the placenta to through the umbilical cord to the fetus and back. We're looking at certain parameters to see how they're doing in each twin. So it's not one specific thing. It is, you know, obviously we want to try to keep those babies inside as long as possible, but there are things that would press our hand if the babies are not doing well on the monitoring, if the blood flow is severely impaired in the umbilical cord, if the growth is such that both babies are having growth issues, if the smaller twin is not doing any growth at all, or if the bigger twin is starting to show signs that it's starting to do worse inside or in utero and would be benefit by being on the outside and in a NICU. So there's not one right answer. It's a bunch of different answers, you know, questions you have to ask to make that decision. And also involving the NICU docs, talking to them to where they can talk to the patients and let them know what to expect in the NICU. There's a bunch of things to consider. But you know, as MFMs managing these pregnancies, we really want to get the patient as far along in the pregnancy as possible. But, you know, if we're pushed because of certain things that are going on with the twins, because they'll let you know by looking at all those parameters I just mentioned when it's time, then they would have to be delivered. I think the earliest, I mean, we just had a set of 25 weekers that were twin transfusion that had to be delivered. And they're actually both still doing okay in the NICU. But at the same time, you know, that's not always the case. And I think to touch on what we were talking about before, um, you really don't know how they're going to do until they're in the NICU. And that's where you could jump in and talk before I interrupted you about, you know, what are some of the things that you're looking for when you are given a twin transfusion set of twins in a NICU.
yeah, thank you. So the, you know, I won't go through it all
Mm-hmm.
because I don't know that we need to do a master class in neonatology. But
Mm-hmm.
um, what's interesting about the condition is that the two twins have almost opposite problems.
Mm-hmm.
Um, so the donor twin, um, oh, thank you. Sorry, somebody just shared the video, shared our live video. I didn't know that you could do that. But yes,
Yeah.
if other viewers wish
Mm-hmm.
to share our live video and get a greater discussion going, that's great. Um, so the small twin, I mean, we talked about them potentially being a stuck twin, but the smaller of the twin can have kidney problems. They may not pee actually that well in
Mm-hmm.
the womb, which is why they don't have a lot of amniotic fluid. But then also after birth, they may have some kidney injury that takes some time to recover. So parents need to expect that that baby, if they're not peeing, that may take a few days. And markers of their kidney function may rise. and it may look like their kidneys might not recover, but they often do. Um, the other thing about the small twin, obviously they're small, and when they're small, they may have trouble with things like maintaining a blood sugar.
Mm-hmm.
They may have trouble with their body temperature. Um, they don't have a lot of um, um, muscle mass. They're generally quite small, and because they're small, they may take a long time to actually get home. The average baby to go home needs to be about 4 pounds as a minimum. And so, if you're born at, sorry, I'm thinking grams, but 1,200 grams.
Mm-hmm.
Uh, if
Mm-hmm.
you're born at 1,200 grams, which is about 2.6 pounds, it's going to take you a little while to grow in the NICU.
Mm-hmm.
These babies also, when they're quite small and fluid restricted, one of the things that you would be well versed in is they don't tolerate labor very well.
No.
Um,
Mm-mm.
and so they may pass meconium. We talked about that before. They may pass poop in the womb. And if they inhale it, that can lead to that condition called meconium aspiration syndrome that we've talked about. Strangely enough, though, the smaller twin, and the other thing that the smaller twin has is often anemia because they're giving blood to the other
Yeah.
twin. But the strange thing about it is if you asked me which one, if I was on call and I had to pick one
Mm-hmm.
that I was going to pick that I had to care for, it's actually the donor that's the easier one to care for often. The recipient twin, um, they have received so much blood
Mm-hmm.
that they have so many problems related to that. Their
Mm-hmm.
heart is working very hard because their blood is so thick.
Mm-hmm.
They may have problems with breathing. They may
Mm-hmm.
have fluid around the lung. They may have fluid around the heart. They may have a congested heart. And you talked about that in adults having congestive heart failure. I believe it was, or maybe you were referring to the baby.
Yeah.
But
Well, yeah, it's a similar,
yeah,
different process, but similar outcome in a way. Yeah.
yeah. And sometimes, believe it or not, what we have to do is we have to do what's called a partial exchange transfusion
Mm-hmm.
and take some of the blood away from this recipient twin because their blood is so thick that just as it's trying to get through the lung, it leads to congestion. Um, and it leads to difficulty with breathing and another condition that you call pulmonary hypertension. So these are and ultimately you can develop a condition if the heart is really failing from too much overload, and this is a whole other thing that I know you deal with, which is the hydropic infant,
Mm-hmm.
where there's so much backup of blood flow that
Mm-hmm.
all the tissues in their body start to
Mm-hmm.
develop fluid, and they have fluid in their belly and fluid around their lungs.
And
Somebody
skin and
actually
skin. Yeah.
said, "Yes, give me the donor twin any day," and that's
Mm-hmm.
and
Mm-hmm.
I think that is common for people to believe that. So those are the sorts of problems, and so. But if you think about which one is going to be the sicker twin, it's often the recipient twin,
Mm-hmm.
um, who's received all that blood. So Shannon, if it's okay with you, I wanted to go through. There was a really good question back here.
Mm-hmm.
Um, just a moment. Uh, lots of comments. Basically, somebody was wondering about laser. Sorry. Oh, here it is. Uh, Jessica, sorry, Petrock. I hope I'm pronouncing that right. It's either Petrock or Pytrock. Um, how successful is the laser therapy to separate the membrane? I am pregnant with monodi twins. So they're asking there about fetoscopic laser ablation of vessels. And so what is the
Yeah.
success
So
rate?
so we're not separating the membrane.
No.
You want the membrane to stay there. What you're doing is they go in and they look. You have one baby in one sac, one in the other, and you look at the surface of the placenta that they share to see the vessels that are crossing the membrane, and they're connecting the two sides of the placenta with each twin. So that's what you're looking at. And then they laser those connecting vessels in order to prevent the shunting of the blood to the recipient twin. That is not what I do.
No. No.
Yeah. So I don't know. I think it's going to depend as far as I can get. I can't give you the stats on that. It's going to depend on how advanced the process is. When they, as far as the stage of the twin transfusion syndrome, before they start. I mean, before they go in to do the laser, basically that's the main outcome. I mean, I think every center that does this is going to have a little bit of different stats as far as their success rate goes. So that's something you would have to ask the center where you would go for the consultation for the laser therapy if it's needed. Not all twin transfusion syndrome pregnancies need laser. So that's why we continue to do the surveillance. I've had several sets of twins that stayed in that lower stage and didn't need it. So that's a possibility as well. Just because it starts out doesn't mean it's going to progress. So that's why we have to watch every week, every other week to see where, how it's progressing along and whether or not that laser therapy is indicated.
I think it is fair to say, though, and again, I don't do this either, but
Yeah.
if you are referred for laser therapy, it's because your pregnancy in particular is very high risk for a very bad outcome, and the bad outcome would be generally loss of.
What I will say, what we do though, if they start showing signs, even before they even meet criteria for laser, we'll send them to get plugged in, so that if it's needed, and the docs may say, you know what, you're early enough, it's not time to do laser, let's keep following you, and then we work together. But at least they already know them, and they get the reports every week, every other week, as we are generating the reports, and they'll know the patient already. So even on the earlier stages when we know they're not candidates, but they do qualify, as having early twin transfusion, we'll send them just for a consult so they'll get plugged in. So, but and that's why, again, it's so important to get those ultrasounds, to get that surveillance so that we can get you seen sooner than later. The earlier it can be addressed and managed is the better.
Excellent answer. Which I knew there'd be an excellent answer there. And yes, I'm aware that you don't do that, but certainly I know they start off seeing you and you identify them. But yes, and I think something that you said was so important that, and I realize we're a little over time here. We were scheduled to go to 8:15, but I think something you said that was really important, which is statistics, can be very interesting when you're talking about population statistics or multi-center statistics, where they'll say the successful outcome, the chances of a successful outcome for treatment X is this in this widespread organization. Well, that's great to know, but you really need to know what's the actual outcome in your center.
Yes.
And we saw that. What's very interesting, and I'm sure that you probably heard about this, but Dr. Raisavi, I think it was back in 2015, published basically American data looking at the outcomes from 22 all the way up to like 29 weeks or something in the US, and showed wide variability in successful outcome at 22, 23, 24 weeks. And it's an often quoted paper, but it really struck me as I read it and I saw the intercenter variability, that to say, survival at 22 weeks is 30%, or to say at 23 weeks it's 50%. Well, that's great to know that the average for North America or the America is that. But if you're in a center that's at 10%, I think as a patient you deserve to know that. And quoting general data doesn't help. So I think going back to twins, I think you hit the nail on the head. You need to speak to the people in your center and find out what the outcomes there are.
Every NICU knows what their stats are. They I don't know if it's a requirement. There probably is to a certain level to know how NICU centers are doing with their outcomes, especially for these earlier pregnancies. But every NICU setting or center, every hospital that has a NICU is going to know how their NICU, how they perform, and that's a legitimate question to ask if you're going through something like that, where your child, you might need to be delivered early for whatever reason, and you're anticipating that your child or kids might need a NICU stay.
Yeah, absolutely. I'm just looking to see if we have any questions. Are you okay for one or two questions?
Yeah.
Yeah. I'll see if we have one. Oh, this should be I shouldn't say easy, but this should be one you get asked, I'm sure, a lot. How early can you detect twins?
How early? I mean, you can detect just with the gestational sac earlier on without even a discernible fetal pull. It depends on how early someone gets ultrasounded. So, but there's one thing to consider as well. The earlier you detect them, there's always a chance that there could be something called a vanishing twin. That's one of the things that can happen with twin pregnancies, and that could be in any kind of, whether they're di monodi, or anything like that. Vanishing twin is somewhat common in multiple gestations. So I've seen them dividing membranes in separate gestational sacs, 4, 5, and 6 weeks. Someone might think that they were 6 weeks pregnant, but they came in and they were actually earlier than that. And I see 2 gestational sacs, 2 yolk sacs, but I don't see the fetal pole yet. Then you bring them back in a week or 2 and see how things develop over time and see what eventually results. So you can pick it up pretty early.
Yeah, no, I went through the vanishing twin experience myself. Well, my wife did.
Yeah.
Or we did, I should say. And I remember, that hearing that moment of, oh, there's one, and then I heard, oh, there's a second sac, and then we couldn't find one. But such is life, and as you said, it's extremely common. So I guess that's good.
Well, I actually have some stats for you.
Oh, do you? Yes.
So in the first trimester, a number of patients with multifetal gestations undergo it's called spontaneous reduction of one or more fetuses, and this is referred to as a vanishing twin. So the probability of this reduction increases with the number of gestational sacs. So up to 36% of twin pregnancies can end up with a vanishing twin, 53% for triplets, and 65% for quadruplets. So since we're talking about twins, there's about a 36%. So it could have been that there was a twin earlier on and you just didn't know. And by the time you got the ultrasound, we only saw one baby or one fetus, and that it was actually started out as a twin pregnancy. So it could be that as up to 1/3 of twin pregnancies could have a vanishing twin.
Okay. So Shannon, I wanted to thank you for your time. I think that's the majority of the questions that we have. I do want to answer though from the NICU doc. He's got probably the question of the night, I have to say, is what is the story with the panda behind you? The story of the panda, I am filming from my son's room in the basement. My son has a passion for pandas. And so I believe that is not the only panda in this house, but that is one of our pandas. And so in case that was a burning question, I wanted to clear that one off the table. So Shannon, thank you again for, all right, this question I've got to ask because, is it true that if a person is born left-handed that he or she has most likely had a vanishing twin?
No.
No.
That's pretty easy, no. Where does this stuff come from? Like
I thought I would just let that one go. I knew the answer was no, but I thought I would let the professional answer. No, I would like to thank you, Shannon, again. This has been awesome doing this again with you. Last time on Instagram, this time on TikTok. So
no, we were on TikTok. We were on TikTok last time.
Sorry, did I say were we?
You said Instagram. Yes, we were on TikTok. Because remember, I had to download it. It took me forever. TikTok is harder.
Oh, yes. Sorry, you know what? We were on. That's funny. I was on Instagram with the NICU doc. Sorry.
Yeah, with Prem. Yeah, you were on.
Yeah, Instagram. I was with Prem. Yeah. All right. Well, thank you for joining me again on TikTok.
Thank you.
And have a great night, everyone. And thank you again for joining.
Bye, everybody.
Okay, bye-bye.